folks, this is the first of our 2 reproductive system lectures. This is going to go over the male reproductive system. I'll have a second lecture that talks about the female reproductive system, as well as pregnancy and childbirth. Our objectives for the lecture. We'll start with some anatomy. If you remember from the urinary system lecture, I told you that the male reproductive system is often called the male genitourinary system, and that is because both the urinary and the reproductive systems share the same plumbing, if you will. You have the same ductwork that's ultimately taking both urine and spermatocytes out of the male pelvic cavity. The function of the male reproductive system, actually the function of both reproductive systems, is to make gametes and hormones. Let's do a little bit of vocab first. What is a gamete versus a gonad? We'll see these 2 words in these lectures. So a gamete is a sex cell. And this would be either egg in the female reproductive system or sperm in the male reproductive system. Okay, how about a gonad? What's a gonad? Well, the gamete is a sex cell. The gonad is the sex organ. And usually when I say this, my students are like, oh yes, the organ with which you have sex. No, that's not what it is. This is the organ that makes the gamete. So in the male, this would be the testis. In the female, this would be the ovary. Here we're talking about the male reproductive system. We are talking about the testes. So the testes make gametes, which are reproductive cells, specifically sperm. These are generated by meiosis, and meiosis cuts the number of chromosomes in that cell in half. So remember, you should have 46 chromosomes in every normal cell. One of these comes from mom, one of these comes from dad, so 23 pairs. But in a gamete, either sperm or egg, those are separated, so you just have 23, one copy of each chromosome. And then when those 2 gametes come together, you'll get a copy of each gene in the egg cell, a copy of each gene in the sperm cell. They'll come together and form a new individual with their own specific DNA and with a full chromosome number with 46 chromosomes in each cell. The other function of a gonad, any gonad, is to make hormones. In the male reproductive system, we're talking about testosterone. Testosterone is really important for gamete production. You need really, really, really high levels of T4, of testosterone, to make sperm cells. If you don't have high levels of testosterone, your patient won't be making a lot of sperm cells, or they'll be abnormal. And then hormones just in general, testosterone in this case, regulate secondary sex characteristics. These are things that make men look like men, as opposed to looking like women. So this would be things like increased muscle mass, increased bone density, hair, facial hair, increased body hair, deeper voice. Those kinds of things are secondary sex characteristics. And if you do not have testosterone for those will atrophy or go away. The same is true of hormones in the female reproductive system. They also are important for gamete production and maintaining secondary sex characteristics. Okay, so let's start with the gonad, which are the testes. Male spermatocytes or spermatozoa are produced inside the testes. The testes are suspended outside the body in the scrotum. The scrotum is a sac of skin. I had a physiology professor who screwed up once and called it a sac of sin. It is a sac of skin held outside the body cavity. And spermatocytes are made and stored in the scrotum. Why is it outside the body cavity? Why are testes just out there? None of that seems wise. Very, very liable for injury and for damage. None of that seems like it would be a good way to propagate the species, putting one of the most important elements outside the body where it can be hit. Why would we do that? This is terrible engineering. Take a minute and think. Why would we put the testes outside the body cavity? The reason why they're outside the body cavity in the scrotum has to do with temperature. Sperm cells need lower than body temperature. So your body temperature is 98.6 ideally. Sperm cells need it to be like 96, 95, which is only a very small degree difference. If you went outside on a day that's 98 degrees and you went outside on a day that's 95 degrees, you wouldn't tell the difference. You'd still just be hot. But for a sperm cell, that makes all the difference, because at body temperature, if we get these little guys to 98 degrees and hold them there for a long period of time, they die. And this is true about a lot of things, not just temperature. Sperm cells are not very sturdy. If you get them too hot, they die. If you get them too cold, they die. If you expose them to air, water, light, they die. If you look at them real hard, they die. It does not take a lot to kill off a little spermatocyte. They're made in large numbers, so we're going for quantity over quality. So the reason then why the scrotum is outside the body cavity is to keep the testes at this lower than body temperature. There is a muscle in the scrotum called the cremaster muscle that will raise or lower the scrotum and bring it closer to the body or farther from the body, depending on temperature, on whether or not the testes need to be a little warmer or a little cooler. There's also a setup between the artery and the vein that run down into the scrotum called the pampiniform plexus that also helps to regulate body temperature. So that is why such a very delicate, very important part of the human reproductive system is found outside the body. Spermatozoa are made within the testes, and this starts at puberty, so 12, 13, 14, depending on how old the boy is. And this will go from puberty until the day he dies. Still be making several million spermatocytes every day. Now, the day before he dies, they're probably not going to be very good quality, but still. The gonads are stimulated by two hormones, FSH and LH, that come from the pituitary and play a role in gamete production in both the male and the female reproductive system. We'll talk about these a little more when we talk about the female reproductive system, but they serve the same purpose in both. So FSH is follicle stimulating hormone. And this triggers production of gametes. So if you will, this is what tells the testes to make sperm cells. LH is luteinizing hormone. And this triggers release of gametes. Both of these hormones are named for what they do in the female reproductive system, but the principle is the same in both. So FSH triggers production of sperm cells, and then when those sperm cells are mature, you get a dose of LH, which causes release of the sperm cells into the tubules of the testes. In the female reproductive system, FSH triggers production of an egg cell, LH triggers ovulation, release of that egg cell. So the testes are essentially this big, long, coiled tube called the seminiferous tubule that's wrapped around itself a bunch. And within the cells of this tubule, this is what we see right here, all these little round guys right here, those are the heads of spermatocytes that are being developed. And as they move down, towards the lumen of the tubule as they mature. All these little spermatocyte tails that you see here, this is the opening, the lumen of the tubule here. And then when they get down to the very bottom of, or down to the bottom of the cell, down to the lumen, that's when LH will trigger release of those spermatocytes into that tubule with all of those other little sperm cells. The sperm cells will then go from the testes, that's this thing right here, into the epididymis. The epididymis is storage. stores mature sperm cells. This is where they get their final shape. This is where they develop their swimming ability. Some combining forms to know for the male reproductive system, a few that I want to point out, either test or orchi or orchid. Both of these refer to the testes. Yes, this is the same orchid as the $15 flower that you buy at King Soopers. The bulb of the orchid closely resembles something else. Oschio, don't confuse orchido and oschio. Oschio refers to the scrotum. And then anything with semen or sperm will refer to semen and or sperm. Epididymo obviously refers to the epididymis. Vaso refers to a vessel. Usually you see it referring to the vas deferens. Vesiculo to the seminal vesicle, and then prostato to the prostate. So, like I said, sperm cells are stored in the epididymis, and then at ejaculation are propelled out through a series of ductwork that will take them from the scrotum to the outside world. First via the vas deferens, also called the ductus deferens. This is a place where we do vasectomy. If you do a surgery for vasectomy. From the vas deferens to the ejaculatory duct, which is a little duct that connects to the urethra right near the prostate, and then out the urethra via the penis. Remember that this transports both semen and urine, so we're going to have to clean out the urethra before sperm cells go through there, because remember the pH of urine was about 5. That's pretty acidic. That will kill those little sperm cells. Remember, they're very, very delicate. It doesn't take much to kill them. So we have a means of cleaning out the urethra before those sperm cells go through there so that they don't die off. The very tip of the penis is called the glans. It's covered by either the prepuce or the foreskin. Two different names, same thing. This is what's removed during surgical circumcision. So what do we do to make sure that those little sperm cells don't get killed off by any residual acid from urine that's left behind in the urethra? Well, spermatocytes are transported in a fluid called semen. This mixture of both fluid and cells is what makes semen. And this contains, like I said, both the sperm cells, but also secretion from these 3 glands right here, the seminal vesicles, the prostate gland, and either bulbourethral or Cowper's glands, 2 different names for the same gland. The seminal vesicles are going to help clean out that urethra. They make a fairly alkaline secretion that will neutralize any acid that's still left behind in the urethra. They also make kind of a thick, kind of jelly-like consistency fluid as well that will help sort of congeal the sperm cells together and hold them in the female reproductive tract to make it through the cervix and into the uterus. The seminal vesicles also make a fluid that's very, very high. Well, the fluid that they make is very high in sugar, so that's going to provide food for those sperm cells after they leave the pelvic cavity. So the seminal vesicles are back here. There's 1 on each side of the bladder, 2 little bitty guys. They are right on top of the prostate, which is this right here. And the prostate is where the ejaculatory duct, which is this little tube right here, joins to the urethra. So this is where sperm cells will actually get into the urethra. The prostate gland also makes a very alkaline fluid that will help neutralize the urethra. And then the bulbourethral or Cowper's glands, again, 2 of these, they're these little bitty glands right here on either side of the base of the penis. These also make a very alkaline fluid that's going to clean out the urethra. So the whole idea here is to make sure there's no acid left behind from residual urine that would unfortunately kill off those sperm cells. Some key terms here referring to male anatomy. And that's basically it for the anatomy section for the male reproductive system. It's significantly less complicated than the female reproductive system. It doesn't see the big changes that you see monthly and hormonally with the female reproductive system, so much simpler. Let's get into some clinical stuff then associated with the male reproductive system, and we'll start by talking about infections. And I do a fairly lengthy talk about STDs in the male reproductive system, not because men are like inherently STD riddled, that's not why, but because the female reproductive system is already really long. So this is where that goes. So infections of the male reproductive system, most of them are sexually transmitted. Most common one is chlamydia. Second most common is gonorrhea. We'll talk about both of those. Herpes is also very common, HPV, herpes papilloma virus. Non-sexually transmitted infections of the reproductive system would be ones like mumps, for example. Mumps is one of the M's in our MMR vaccine. Mumps in kids can cause these big, swollen chipmunk cheeks. It's usually not a terrible disease, but the issue with mumps is that it can get into the testes and then cause infertility later in life. So, this boy has mumps when he's 7, and then 20 years later is trying to start a family and can't have kids and can't conceive, and finally finds out it's because he had mumps when he was younger and that virus got into the testes. This is one of the reasons why we vaccinate against mumps. We vaccinate against it to protect the men in the community and to protect that unfortunate side effect of the infection. All right, STDs. This is data from 2016. I haven't found the most recent stuff yet. So I like this. STDs tighten their grip on the nation's health as rates increase for a third year in a row. So in 2016, we saw 1.59, almost 1.6 million cases of chlamydia, almost 500,000 cases of gonorrhea, almost 28,000 cases of syphilis, which are big numbers, but also look at the increase from the previous year. So a 5% increase in chlamydia, almost 20% increase in gonorrhea and syphilis. That's huge. That's a really big increase in both of those infections. In 2017, we saw very similar trends. Almost 2.3 million cases of STDs in the US, looking at total, looking at our three big ones. So 1.7 million cases of chlamydia, so 7% increase over the previous year. 555,000 cases of gonorrhea, again, almost 20% increase over the previous year. And then a 30% increase, or 30,000 cases of syphilis, so 10% increase. And these trends have just continued. What's particularly concerning here is this congenital syphilis, 900 cases of congenital syphilis. Congenital syphilis means a baby who was born to a mother who has an active syphilis infection, and then that syphilis passes to the baby. We'll talk about what syphilis does in newborn babies in a little bit, but it's not pretty. And this rise in syphilis in newborn babies is incredibly concerning. Back in 2013, we had 360-ish. In only 4 years, we've gone up 3 times as much to 900 cases of syphilis in newborn babies. Again, it's a very small number, but the increase, the very fast increase, is very concerning. This is from the BBC from about this time last year. 1 million new STIs every day, according to the World Health Organization, worldwide. That's a lot of infections. Like this, the WHO estimates 1 in 25 people has at least one STI. So let's look at Colorado in 2017. We're still seeing pretty high levels of STDs here. So 27,000 cases of chlamydia, about a 6% increase over the previous year. 8,000, almost 8,500 cases of gonorrhea. Holy cow, 42% increase over the previous year. And then 300-ish cases of syphilis, which is very close to 20% increase over the previous year. That's a lot. That's a lot of percent increase. So let's talk about our 3 big STDs then. Chlamydia is a bacterial infection. Most commonly reported bacterial STD in the US, and it is a reportable disease. If you have a patient who comes in with chlamydia, you will send that information off to the Department of Public Health. Rates of diagnosis of chlamydia are twice as high in women as they are in men. Why that is, we're not entirely certain. MSM stands for men who have sex with men, so they're gay or bisexual men or transgender women are at the greatest risk of undiagnosed chlamydia. So there's a lot that's not happening, a lot of testing that's not happening there. Rates of chlamydia are highest in our young adult population, both men and women. In women, chlamydia is usually asymptomatic, and this will lead to things like pelvic inflammatory disease, which is inflammation of the uterus and the fallopian tubes, which can lead to infertility and ectopic pregnancy later in life. If mom has an active chlamydia infection and delivers a baby, that chlamydia can pass to the baby, and then you'll see issues with eye disorders, eye diseases, sometimes blindness, issues with pneumonia as well in that baby with that chlamydia. So these are rates of reported cases from 2016. Here's our age group right here, and again you can see this 15 to 24-year-old age group in both men and women. Very high peaks of chlamydia. And again, you see higher in women than men. And why that is, we don't know. Why men are not getting tested at the same rate. There's some kind of gap there that we're not catching. Gonorrhea is also bacterial, Neisseria gonorrhea. This is the second most commonly reported bacterial STD in the US. In gonorrhea, we see more men than women affected. This is the opposite of the last one. The big concern about gonorrhea, especially in the last couple of years, are these drug-resistant strains of the bacteria. We're getting gonorrhea that is very, very difficult to treat. There have been a couple cases of what they call super gonorrhea that cannot be treated by any antibiotics. So I'm not gonna, not assuming that any of you have had gonorrhea, but if you have, or even if you haven't, just imagine you now have an STD that you can never get rid of. Nothing about that sounds pleasant. The big concern about gonorrhea is that it increases your susceptibility to HIV. It causes little sores, usually on the inside of the reproductive tract, so within the urethra or within the vagina, and those sores make it very easy for HIV to pass into the body. So if you have gonorrhea, there's a big concern that you are much more likely to catch HIV. In women, just like we saw in chlamydia, it leads to pelvic inflammatory disease, and then you can see infertility later in life. In men, you see issues with inflammation of the epididymis and the prostate, which can also lead to issues with infertility later in life. This concern about drug-resistant gonorrhea has been a topic of conversation for several years now. These are all headlines that I found across the internet from recent years. Antibiotic-resistant gonorrhea found in 2 UK women down there on the right. Our greatest fear, highly drug-resistant gonorrhea. I don't know what your greatest fear is, but that's their greatest fear. Super gonorrhea, start of a drug-resistant STI boom. And that's kind of important to point out. Gonorrhea is not the only one that's not going to be able to be treated by antibiotics. We're going to see the same issues with syphilis and chlamydia. Experts brace for more super-resistant gonorrhea, super drug-resistant gonorrhea coming to US. I like this one right here in the middle. Wherever you are in the world, time is running out for treating gonorrhea. So, get yourself tested. These are rates of gonorrhea in the US from 2017 to 2016, and they show such an interesting trend, I think. Prior to 2012, we saw more gonorrhea in women than we did in men. Right, that gray line is women. And then I have no idea what happened after 2012, but we see very high rates of gonorrhea just shooting up and more gonorrhea in men than in women. We see this flip and reverse. Why that happened, I do not know. Syphilis is the last of our big 3 STDs, again, bacterial. This syphilis affects more than just the reproductive system. Syphilis can get into other organs in your body and hang out in your body for a really long time. We're seeing very high rates of syphilis, again, in men who have sex with men. That's kind of our population that's most at risk. Usually syphilis is pretty asymptomatic or very mild symptoms. Sometimes you'll see a rash with a syphilis infection, sometimes not. But again, the concern with it is it can spread to other organs in the body, especially the brain. And then you'll see issues with blindness, sometimes paralysis, sometimes symptoms somewhat like dementia or Alzheimer's. Those symptoms cannot be reversed. And then just like gonorrhea, if you have syphilis infection, that increases your risk of getting HIV. Syphilis is a spirochete bacteria, which just means it's shaped like a little corkscrew. And that bacteria corkscrews its way into your skin. Think about opening up a wine bottle. And that corkscrewing of the bacteria into your skin is what causes little sores on the skin. And then HIV can travel across those sores and get into the body. Now, I mentioned congenital syphilis. This is kind of our big concern with these rising rates of syphilis. So a mom has an active syphilis infection, isn't treated for it, gives birth vaginally to a baby who's then exposed to syphilis. Syphilis can cause issues with stillbirth, miscarriage, premature birth, but then also issues with blindness and deafness. A baby who's born to a mother with an active syphilis infection has a very high risk of being blind because of that bacteria that gets into the eyes. This is why, once that baby is born, one of the first things that you do is put that little strip of antibiotic ointment in the eye. Those of you who have had kids or seen a baby born, one of the first treatments is the antibiotics in the eye because you don't know what mom might have picked up since the last time that you tested her for STDs. And you want to prevent that eye infection and that blindness in that baby. This is showing rates of syphilis. This is over 36 states. I don't know what happened to the other 14 that they did not report, but you can see this huge gap here in syphilis rates between men who have sex with men, men who have sex with women, and women. So higher rates in men who have sex with men, and then slightly higher rates in men who have sex with women than in women. And you can see, again, just a steady overall trend upwards, which is true of all of our STDs. So this is just kind of a basic wrap-up about STI information. This comes from the American Social Health Organization. So 1 out of all 4 teens in the US contracts an STI every year. By age 25, half of all sexually active adults will contract an STI. You know how old you are, you know if you fall into that category. Currently, there's no cure for viral STIs. This is stuff like hepatitis, HPV, herpes, HIV. Women are more likely to be asymptomatic than men, which means they'll have that STD but not show symptoms of it. But you often see men being asymptomatic as well, having gonorrhea or having syphilis and not showing it. Condoms will protect against STIs that are spread through body fluids, and this is stuff like gonorrhea, chlamydia, HIV, but there are STIs that can be spread from skin-to-skin contact, stuff like herpes, chancroids, syphilis. If you have an infection on the skin that comes in contact with other skin, you can transmit, say, syphilis from one person to another like that. Remember that you can have STI infections in more than just the reproductive tract. You can have gonorrhea of, say, the mouth or the throat or the anus, depending on where sexual contact is occurring. So there is no guaranteed method of STI prevention. Condoms are a good place to start. The CDC recommends that you get tested for sexually transmitted infections at least once a year. If you are in a high-risk category, recommended that you get tested more often, more like once every 3 months. High-risk category would be something like, obviously, men who have sex with men, we saw are at very high risk of certain STIs. If you have a large number of sexual partners, if you have sex for drugs or money, or if you have had sex with someone who has had sex for drugs or money, All of those would put you at high risk of getting an STI. So hopefully by now you're saying, oh my gosh, this is terrifying. Good. Your next question should then be, what do I do to go get tested? Also good. There are lots of places that you can go for STI testing. You can obviously go to your doctor and request a full STI panel. They should test you for everything, including HIV. You can go to the Tri-County Health Department, which is the public health department that serves Douglas, Arapahoe, and Adams County. They do STI testing and counseling. There are also other clinics in the area that do STI testing, some of them for free. If you want resources or have questions about testing or are asking for a friend, send me an email. I would be happy to send you a list. Okay, moving on from STIs. Let's look at some stuff that's specific to the male reproductive system. Most of these diseases we've talked about already. Okay, benign prostatic hyperplasia, you see abbreviated BPH. What does the word benign mean? Benign means essentially not bad. The opposite of benign is malignant. And you probably recognize that prefix mal. Mal means bad. So by bad and not bad, we're basically referring to whether or not something is cancerous. If you have a benign growth in the body, that is not a cancerous growth or not a cancerous tumor. If you have a malignant tumor in the body, then it is cancerous. That's the difference between the two. So benign prostatic hyperplasia is increased growth of the prostate, but it's not cancer. It's just something that you generally see as men get older. The prostate gets a little bigger due to changes in testosterone in the body. Now, this causes some problems because then the prostate, remember, wraps around the urethra. The urethra goes right through the prostate. So if the prostate gets bigger, it will start to compress the urethra, and then you'll see issues with urination. Not emptying the bladder all the way, not being able to start urination, feeling like you have to urinate all the time. Sometimes if it's difficult to urinate, if you retain urine in the bladder, then you'll see infection with that urinary obstruction and urinary retention. Different treatments for BPH. There are medications that will help to relax the prostate. There are medications that will interact with testosterone around the prostate to make it more responsive. Saw palmetto is an over-the-counter kind of herbal remedy that seems to have some pretty good effects for like mild BPH. If it's very severe and it's not really responding well to medication, you may do a prostatectomy, which is removal of part or all of the prostate. And this is done using a TURP, a transurethral resection of the prostate, which is about as terrifying as it sounds. You go through the urethra, up the penis with a scope, and through that scope you cut into the prostate and remove part or all of the prostate, depending on what's going on. Obviously, this is very tricky surgery. There's a lot of delicate stuff around there. You don't want to damage the bladder. You don't want to damage the urethra. But this is what you would do to remove part of the prostate, either for BPH or if you had a patient with prostate cancer. Speaking of which, prostate cancer is the most common malignancy that you see in men in the US. Estimated that 1 out of 6 men will be diagnosed with prostate cancer. I saw one study that suggested that if all men lived long enough, they would all eventually get prostate cancer. Third leading cause of cancer-related deaths in men. First is lung cancer, second is colon, third is prostate, to the best of my knowledge. The reason why it's a leading cause of cancer-related deaths, it can spread very quickly, and it's difficult to remove the prostate. We just took a look at how you remove the prostate. Remember, there's a lot of very delicate stuff around there that you don't want to remove. Treatment for prostate cancer, either obviously chemotherapy and radiation, and then prostate cancer tends to grow off of hormones, specifically androgens, which are male hormones, kind of like testosterone. So you'll give medication that will interact with testosterone at the prostate to keep it from stimulating that cancer. Now, testicular cancer is very, very different in its population than prostate cancer is. Prostate cancer is the cancer of your grandfather. Testicular cancer usually shows up in younger men. This is the cancer of your boyfriend or your husband. Now, it's very, very rare, less than 1% of all cancer in men. But again, it shows up fairly young in life, and it doesn't really have any kind of genetic tendency. It's not a cancer that runs in families. Treatment for testicular cancer will involve, yes, removing the testes, removing that infected testis, and then chemo and radiation. I had a student, when we were talking about this, he asked, after you remove that testis for testicular cancer, can you do any kind of reconstructive surgery, the same way you would after a mastectomy for breast cancer? I made him look it up because I wasn't going to type that into my work computer, but yes, it turns out they do make prosthetic testicles after you've had one removed for testicular cancer. They cost between $3,000 to $5,000. Facts that you never thought you'd needed to know. Risk factors for developing testicular cancer. Being Caucasian for whatever reason. Cryptorchidism is probably the biggest one. If you have any kind of fertility issues, so low sperm count, you're not making a lot of sperm, or they have kind of a weird shape. Hypospadias, which is this weird condition where the urethra comes out on the underside of the penis instead of at the end at the tip of the penis. So any kind of abnormality just in the reproductive organs. An inguinal hernia, which we'll look at in a little bit. If you have HIV or AIDS, that will increase your risk of testicular cancer. So what is cryptorchidism? The testes should normally be in the scrotum by birth. The testes develop up in the abdomen, kind of near the kidneys. And then as a baby is developing in utero, the testes descend down into the scrotum by means of a little muscle called the gubernaculum that sort of pulls them down into the scrotum. If the testes are not down in the scrotum by birth, often that will correct itself within the first year of life. The testes will descend down into the scrotum. If not, then we have cryptorchidism. The word crypto means hidden. So he has a testis, it's just hidden up in the abdomen. This needs to be surgically corrected. You'll go in and surgically move that testis down into the scrotum because remember, why are the testes held outside the body cavity? Right? They're out there because of temperature. If that cryptorchidism is not reversed, then this man is looking at sterility, potential sterility for the rest of his life, especially if both testes are up in the abdominal cavity. This also, again, increases that risk of testicular cancer. So like I said, normally the testes should be down in the scrotum by birth. They can be up in the abdomen or in the inguinal canal. This is the little pathway that they take to get down into the scrotum. The lower the testes are, if they're in the upper scrotum or if they're in the inguinal canal, the easier it is to fix that cryptorchidism. Infertility refers to any inability or decreased ability to reproduce. If you have a couple that comes in talking about infertility, we've been trying for a year, we can't get pregnant, usually about a third of the time it's because of the man, about a third of the time it's because of the woman, and then the other third of the time we can't really find the cause of infertility. Regarding male infertility, there are lots of different things that can contribute to this. Sometimes it can be hereditary. Maybe he just has a naturally low sperm count. It can be issues with hormones. Low testosterone is a big one. You need very high levels of testosterone in the testes to make and sustain sperm levels. Disease, we talked about mumps. If that mumps infection got into the testes, that can damage them and render them incapable of making sperm cells. There are certain chemicals that will damage the testes as well. And again, STDs that damage the testes or the epididymis will lead to infertility. Complete inability to reproduce is sterility. If this is done voluntarily, hopefully, this is done with a vasectomy, cutting and suturing the vas deferens to keep sperm cells from getting from the testes up into the pelvic cavity. Sometimes infertility can be addressed, sometimes not. It depends on which of these reasons. There might be multiple ones. are causing the infertility. Erectile dysfunction, or ED, is also called impotence. This is inability to perform intercourse, either because he cannot initiate or maintain an erection. Lots of causes for this. It can be psychogenic. Actually, there are a lot of studies linking stuff like increased porn use to issues with ED. It can be due to physical or neurological stuff. It can be pharmacological. You need pretty high blood pressure to maintain an erection, and if your patient has low blood pressure for whatever reason, that might be the cause of it. Treatments for ED, the most popular one, the one with all the weird, slightly uncomfortable ads on TV, is Viagra or sildenafil. Sildenafil was not originally developed as an erectile dysfunction medication. It was originally developed for patients who have low blood pressure, just naturally low blood pressure. And in the initial tests that Pfizer did with sildenafil, when they started testing it to see how it worked in patients, it wound up being kind of unimpressive as a blood pressure medication. It didn't really have the results they were hoping for. So Pfizer called all of their study participants and said, "Thank you very much for your time. Here's your money for participating in our study. Please send back all your samples of sildenafil." And they got all the samples back, and then all of the old men called Pfizer and were like, "You're not gonna believe this, but..." And that's how Pfizer figured out that sildenafil would be a pretty lousy blood pressure medication, but would do pretty well for erectile dysfunction. Now, you will occasionally see a patient on sildenafil for its low blood pressure benefits. You'll see women, you'll see children occasionally on sildenafil because of its original development. Anyway, that's the main treatment for erectile dysfunction. There are also prostheses and vacuum pumps that will help to pull blood into the penile tissue, but generally speaking, drugs are the most common one. Inguinal hernias occur when you get a loop of intestine caught in the inguinal canal. The inguinal canal is the little canal through which the testes descend into the scrotum. The inguinal canal is bigger in men than it is in women because the men have testes going through into the scrotum. And sometimes you'll get a loop of sometimes you'll get a loop of intestine caught in the inguinal canal, which will lead to a hernia. There are different types, direct or indirect. This just has to do with which level of the scrotum the hernia is caught in. A strangulated hernia occurs when you get a whole loop of intestine that's caught in that inguinal canal. This will need to be surgically repaired. You'll go in and do a herniorrhaphy. Our suffix raphy here means to suture. So you're going in, pulling the loop of intestine out of the hernia, and then suturing the inguinal canal a little smaller so that it's harder for intestine to get caught in it. So here's our example here of an inguinal hernia. You can see the inguinal canal and then this loop of intestine that's gotten caught in there. That's what we see, this bulge at the top of the scrotum and this bulge right here. Again, that will need to be surgically repaired so that you don't have issues with the intestines or blockage of the intestines. Very, very painful, very unpleasant experience. This is just what we mean by direct versus indirect inguinal hernia. It has to do with which of the inguinal rings the loop is caught in, if it's caught in the superficial and the deep, or if it's just caught under the deep inguinal ring. And that is that for the male reproductive system. If you have questions about anything that we went over, or if you, again, would like information on where to go to get good STD testing, you're asking for a friend, send me an email or drop by office hours and we can chat.